Welcome to the chapter on percutaneous cordotomy and trigeminal tractotomy for pain. The purpose of this chapter is to discuss the two most common spinal ablation procedures performed for intractable pain. The history, indications, surgical techniques, methods of target verification, available evidence, and potential complications will be discussed for percutaneous cordotomy and trigeminal tractotomy nucleotomy. The underlying principle of spinal ablation is the creation of a discrete lesion within a compact bundle of nerve fibers or cell bodies that interrupts the propagation of noxious stimuli from a defined area of the body. Such an intervention is usually indicated in cases of intractable pain with or without terminal or debilitating conditions when other methods have failed or the projected survival time does not afford the exploration of alternative therapies. The earliest versions of these procedures were performed open, involving either a knife section of the anterolateral spinal cord or a transverse stab incision dorsal to the olive, the associated morbidity and mortality of which rendered them risky procedures. In the 1960s, the second iteration of these procedures involved transitioning to percutaneous approaches. Cordotomy was made percutaneous through the pioneering efforts of Molin and Razumov, while Hitchcock developed a stereotactic apparatus specifically for trigeminal tractotomy and myelotomy. The third renovation consisted of an introduction of CT guidance to both procedures by Campbellot. The modern versions of these procedures are accomplished using CT guidance with intraoperative monitoring and sometimes under general anesthesia. Cordotomy is in essence a lateral spinothalamic tractotomy. The spinothalamic tract carries nociceptive signals, temperature, and non-discriminative touch from the contralateral side of the body. There are two subdivisions of the spinothalamic tract. First, the neospinothalamic tract, also known as the lateral spinothalamic tract, is devoted to the conduction of thermal and nociceptive discriminative sensations. Second, the paleospinal reticular tract is particularly responsive to the intensity of noxious tissue damage, with diffusing projections on the reticular formation and the nonspecific thalamic nuclei, including the centromedian, parafascicular, and interlaminar nuclei. Shown in Figure 1 is the somatotopic organization of axons within the neospinothalamic tract. Fibers entering from rostral and caudal segments are located in the medial and lateral parts of the tract, respectively. The neospinothalamic tract terminates mainly in the ventroposterolateral nucleus, ventroposteromedial nucleus, the interlaminar nuclei, and the posterior complex. The candidacy for cordotomy has evolved over time. Originally, it was widely used for chronic non-cancerous pain, but has gradually transitioned to mostly cancer-related indications at the present. The ideal candidate is a cancer patient with unilateral somatic pain with a life expectancy of around 1 year. However, extremely frail patients with intractable non-cancerous pain could also be treated with cordotomy. Bilateral pain is harder to treat, midline pain is not an indication, and pain above the C5 dermatome is not usually managed with cordotomy. Pulmonary function tests with greater than 50% preservation of FEV1 and FVC are generally the minimal cutoffs for surgical candidacy due to the risk of central apnea or hypopnea following cordotomy. Mesothelioma represents a particularly suitable malignancy for treatment using cordotomy, given its unilateral nature and somatic type of pain resulting from the involvement of the pleura and ribs. Involvement of the pulmonary parenchyma to the point of reducing pulmonary functions beyond the minimal cutoff for cordotomy does not occur until late in the disease course, imparting a favorable risk-to-benefit ratio. A kit for CT-guided spinal cord radiofrequency lesioning made by LCE Cosman is used to perform the procedure. A radiofrequency lesion generator that is capable of stimulation and impedance monitoring, which is available from multiple manufacturers, is also required. The procedure is commonly performed with the CT scanner in the radiology suite. However, with the recent availability of wide-bore mobile intraoperative CT scanners, the procedure can be done in the operating room. A lumbar injection of 12 cc of contrast is injected 30 minutes prior to the procedure, and the patient is kept in the Trendelenburg position to facilitate diffusion to the cervical region. The level of choice to perform the procedure is between C1 and C2, where there is a lateral space to allow introduction of the needle. The laser beam of the scanner is used to guide entry into the skin at this point. The adequate infiltration with local anesthetic before and during cannula introduction helps ameliorate pain due to contact with the sensitive dura and C2 ganglion. After free flow of CSF is observed, another CT scan is always obtained. According to the previously determined lateral diameter of the spinal cord, the length of the exposed tip of the electrode is then adjusted on the hub of the electrode before introduction through the cannula. Cord penetration is accompanied by a rapid rise in the impedance from typical CSF values of below 400 ohms to around 1000 ohms. Mild pain or electrical sensations are also usually detected by the patient. A CT is used to check the position of the electrode in relation to the geometry of the spinal cord. The tip of the electrode should be in the anterolateral quadrant of the cord opposite the side of the pain as exemplified in the picture on the right. The area of maximal pain intensity and the somatotopic arrangement of the pain fibers within the spinothalamic tract relative to the electrode position may also be evaluated. Anteromedial progression within the cord will target more posterolateral pain regions. Usually cord penetration produces pain in the area to be ablated. Electrical stimulation of the target also reproduces this phenomenon. Impedance monitoring is primarily beneficial for identifying cord penetration. It possesses very limited utility in regard to verification of the target within the spinal cord. Macrostimulation is performed with sensory and motor frequencies to test for hypoesthesia and motor response during lesioning. A test lesion is made before creating a second lesion for therapeutic effect. The benchmark of successful lesioning is the abolition of distinction between sharp pinprick and dull sensations. Most cordotomy evidence pertains to cancer pain only, and evidence supporting non-cancer related pain comes from relatively older studies. There are, however, some challenges to this paradigm by case reports of prolonged pain relief after cordotomy for non-malignant pain. In 2 case series of CT-guided cordotomy, immediate post-operative results consisted of 92 to 98% pain relief that declined to 80 to 84% at 6 months post-op. In both series, there were no permanent neurological deficits and essentially zero incidence of Ondine's curse, which seems to be completely avoidable using CT guidance and careful patient selection. In a recent structured review of all ablative procedures, evidence for cordotomy was assigned a grade of 1C, corresponding to a strong recommendation for use based on a low level of evidence. In 2019, a randomized controlled trial demonstrated the superiority of cordotomy to best medical therapy. CT-guided cordotomy is a safe procedure. There have been no reported mortalities in the literature compared to the 6.25% mortality rate reported for the older fluoroscopic method. The anterolateral quadrant of the spinal cord also carries autonomic pathways for vasomotor and genitourinary control in addition to the reticulospinal tract, which controls ipsilateral automatic respiration. Therefore, sleep apnea, also called Ondine's curse, incontinence, and hypotension are possible undesirable effects of cordotomy. A true Ondine's curse is universally fatal, but no cases have been reported thus far using CT-guided cordotomy. Post-cordotomy painful sensory loss or dysesthesia affects 5% of patients. It is more common in long-term survivors with significant neuropathic pain that received a large lesion. The ventral spinocerebellar tract overlies the lateral spinothalamic tract, and a lesion that eliminates the spinocerebellar tract may cause ipsilateral upper limb ataxia. Mirror pain is a rare, troubling, and unpredictable consequence of cordotomy that could possibly be attributable to either a bilateral pain syndrome that is masked by marked severity on one side, or due to bilateral projection of the dorsal roots in both spinothalamic tracts. Unintentional injection of local anesthetic that is mistaken for water-soluble dye into the CSF could lead to respiratory cessation, especially in the case of a cisternal injection. Clear marking of injection syringes and complete discarding of local anesthetics from the field is therefore a necessity. Cordotomy is one procedure that is poised to be popularized again for several reasons. First is the rising costs of maintaining and managing complications of intrathecal opioid systems in the context of increasing need for cost-effective procedures as a society. Second is that pharmacological neuromodulation is not always completely reversible. Third is the mounting recognition of the phenomenon of opioid-induced hyperalgesia. Finally, there is the increased safety, accuracy, and precision of cordotomy procedures in the advent of intraoperative monitoring and neuronavigation. With wider-bore intraoperative CT scanners, cordotomy will move back to the operating room from the radiological suite. Endoscopic cordotomy, pictured on the right, has also been introduced recently, which presents the potential for improved visualization of the spatial relationship between the lesioning device and the spinal cord. Intractable pain in the face can be one of the most devastating ailments in the human experience. Sensory input from the head via the 5th, 7th, 9th, and 10th cranial nerves are carried by the trigeminal tract to the spinal nucleus of the trigeminal nerve. The immediate juxtaposition of the trigeminal nucleus to the trigeminal tract renders any trigeminal tractotomy an effective tractotomy and nucleotomy, hence the name trigeminal tractotomy nucleotomy. Trigeminal neuropathic pain with varying degrees of trigeminal nerve damage and neuropathy present the main candidacy for TRNC. Conditions such as traumatic trigeminal neuropathy, postherpetic neuralgia, cancer pain of the head and or face, glossopharyngeal and geniculate neuralgia, bilateral trigeminal neuralgia, or possibly anesthesia dolorosa are the typical indications for TRNC. TRNC dates back as far as 1937 when Sjögvist surgically severed the trigeminal tract through a transverse incision in the dorsal medulla. Trigeminal tractotomy was reserved for intractable terminal pain and, because of the extreme morbidity of the open procedures, was seldom ever used. When Crewe and Hitchcock developed a stereotactic technique and device to lesion the trigeminal tract percutaneously, the procedure saw a resurrection in the late 60s. In the early 90s, Campolat described and performed a CT-guided TRNC which allowed direct visualization of the electrode-target relationship. A patient positioned within the CT scanner with electrodes in place for neuromonitoring and a cannula in place for tractotomy is pictured on the right. To use an intraoperative scanner for TRNC, a wide-bore aperture is recommended to allow for scanning while the needle and electrode are in place without collision of the electrode with the CT scanner. TRNC under general anesthesia aids in the maintenance of a prone position for patients with sensitive facial pain. Some surgeons perform the procedure in the lateral position to circumvent this problem. When general anesthesia is used, muscle relaxants should be withheld to allow for motor stimulation and electrophysiologic verification of the target. With intraoperative CT guidance, a 3-pin head holder is often used. Adequate flexion of the head to allow opening of the space between C0 and C1 is critical. The entry point is usually 2 to 3 centimeters off of the midline, ipsilateral to the side of the lesion at the axial level determined by the laser beam on the skin corresponding to the level of the space between C0 and C1. The target is the posterolateral sulcus on the spinal-medullary junction, approximately halfway between the midline and the equator of the cord dorsally. Medial displacement of the target will lead to lesioning of the gracile or cuneate tracts, while ventral displacement risks missing the tract. Proximity of the spinocerebellar tract to the trigeminal tract confers a risk of ipsilateral upper extremity ataxia that is almost unavoidable after this procedure. However, it is usually mild and/or temporary. CT scanning is used to check the position of the electrode in relation to the geometry of the spinal cord. The figure on the right depicts the final position of the electrode. Usually, cord penetration produces pain in the area that is to be ablated. Electric stimulation also produces sensations that confirm the specific target. This phenomenon is only present in awake patients, and when general anesthesia is utilized, there is no clinical verification of the target. However, stimulation of the nucleus of the trigeminal tract is extremely painful. Motor frequency stimulation is performed irrespective of the type of anesthesia and is used to rule out the proximity to motor tracts. If patients are awake, creation of the lesion itself is painful and lower temperatures over longer periods has been advocated by Campolat. Having switched to a sleep TRNC, the author of this chapter has found that 2 lesions created using a temperature of 75 degrees for 90 seconds usually suffices. With thoughtful patient selection, adequate pain control rates exceed 90% with follow-up of up to 4 years. Campolat reported a drop in the median VAS from 7.7 preoperatively to 2.39 postoperatively, and an average increase of 20 points on the Karnofsky Performance Scale. Complications and side effects include ipsilateral upper extremity ataxia, which is usually mild but common, CSF leak, meningitis, or persistence of pain. In conclusion, neuroablation of the spinothalamic tract or the trigeminal tract is an effective method for control of intractable pain. These are not first-line treatments but can be an effective strategy in the right context for severe refractory pain. There is a renewed interest in these procedures due to technological advances and the emergence of new indications for patients who fail neuromodulation therapy. Intractable somatic cancer pain of one side of the body is the ideal indication for cordotomy, while neuropathic or malignant unilateral facial pain is the main indication for trigeminal tractotomy. Thank you for listening.